Hello, we are uh, together today in the third webinar, ASCO-GOIS International Webinar. This session is shared by Professor Eduardo Gazab, who is with us now, and Professor David Kerr sent for us his lecture as he is now in his way into China to meet the prime China, president of China. And we are I speak slowly now because I leave some time for colleagues to join. The focus of these three webinars is on how, via scientific approaches, to lower the total cost of systemic therapy without compromising the outcome on patients. As we agreed together, and I'm sure that Professor Eduardo Gazab shared me this opinion, and David Kerr, and all of us, we have a common vision that we are not speaking about complaining the awareness of cancer problem, how cancer affect me, and how destroy my life. This is could be for others. This is very useful awareness about the role of cancer treatment. This could be for others, for social worker, for politicians, for cinema producers. But people wait from us what to do in pharmacology, in radiation oncology, in surgery, in genomics, whatever. We are doctors and scientists, and how to reduce the burden of affordability of better value cancer care. I say this and I stress on this because there are a lot of speaking and about complaint and about this. Sometimes maybe it is useful, very useful, but sometimes increase the burden on patients because how cancer destroy my life, how cancer is affect. Remember that cancer is one of the problems. There are 100 million person in this world that have uh, resistant tuberculosis, and this is problem. There are 2 millions of people have HIV. We think that is finished the problem. No, 2 millions, and this is also disturbing the life. And there are many problems. There are 10% of the people in the world, at least. I have no statistic exactly because it is there are many world that the many part of the world didn't give their accurate number, but it is about 10% at least of people are handicapped or lose their arm or their leg or something. So cancer is one of the biggest problem in the world, but not the only one. Also, as you see, as we agreed together, we have a message. All of you received it, and I can send it to you again. Please be the voice of 1 billion person in the world who will go tonight to bed, hunger, without food. Yes, 1 billion. And there are 2 billion persons at least who have severe malnutrition. Why we say this while we are oncology and cancer care? Because this is always the excuse. This cancer is not the priority, so we give some awareness, some cancer day, world something, and but we say that there are enough food in the world. This is not excuse. And the approach is the same, scientific approaches to solve. Our role is to search for solutions, not just find some drugs or some solutions which is not affordable and increase the problem. We should be, this is not my opinion, and it is opinion of all our leaders here, and or the win-win initiative or the leader. I'm not the inventor of all this, but I'm just a coordinator. I'm just slightly active. But I speak on behalf of all and on behalf of you, because this message will not succeed without you to be their leaders. By science, we can find many solutions, and hence, in the same time, for it is not the question as it's posed in one of the Medscape by an American citizen, human being, asking food or cancer treatment. We say it could be both. It should be both, and it is possible. Yes, I know that some people think that this is some wishes or some idealistic or some romantic. No, you will see, and we saw before in our presentation, in our program, and you will see today, maybe we speak about different initiatives, but in the upcoming fourth and fifth webinars, you will find many scientific solutions to how to reduce the cost of cancer chemotherapy, systemic drugs without compromising the outcome. It is not at all treatment for the poor or stratified. If you have this sum of money, then you take treatment according to it, and this is all. We are not for that. For stratified, for guidelines for the poor, and this is not our job. These are others who can do this, and we are very thankful for them. But our job is to search and to find, and we didn't invent anything. You will be surprised that there are many solutions published by many authors, but nobody listens. No, it is we don't say this by sympathy or by romantic feelings, but because if we continue as we are, the gap will increase in the upcoming year, despite of all these false promises and plans, and the economy of many countries could not cope. Most of the countries are not coping now, but will not cope even in the rich countries. This is our message together. I have the honor to present a very distinguished personality in this world, and a very dear old friend, and one of the co-founder of this work along years, Professor Eduardo Gazap.
Thank you very much, Professor El-Sawawi. Thank you for your kind invitation and your continuous leadership. Why are we here today? Why are we giving our time to the issue of global cancer control and other health problems that are today urgent to face in the current world? Today, in this series of GOIS ASCO international webinars, the questions are about better scientific options and resource adequate alternatives for cancer treatment and control. And we have always the same discussion all over the world, the issue of low and middle income countries and rich countries. And that is not true. We have today problems for cancer care and control, even in rich countries. There are inequities. There are a lot of differences, racial, cultural, even in countries with wealthy and with enough resources. And at the same time, in the so-called low and middle income countries, money exists. In most countries of the world, the governments are making important monetary investments, not only in Europe and the US and Canada, but also in many countries of Latin America and Africa. In the case of my country, Argentina, the government is allocating 10% of the GDP of the country for health. And the results are not so good, can be improved. But on the other hand, there is a waste of resources in unnecessary things, not only in diagnostic, but also in therapeutic and survivorship aspects. The issue is to apply our resources for health in the best possible way. And you will hear from people that are today leading a new way to face health. The way is one, to protect the healthy populations, because today one of the objectives of medicine is not only to cure, is to avoid disease. We need to take care of the healthy populations, to have diseases at an early stage of development, and to have treatments with low volume of disease. And I think that many of the speakers that we will have today will make points on this aspect. Thank you, Dr. El Sawawi, for gathering this brilliant group of speakers that I think will enlighten to our audience about new strategies and avenues in order to have a better future for healthcare, control, cancer care globally. So I think that following the agenda, we will have first a recorded presentation from myself. Is this correct, Dr. El Sawawi?
Yes, yes,
And
yes.
then we will follow with the agenda. Thank you very much for
I
your
would like to ask you
attendance.
something,
And
please.
Dr. El Sawawi, your words, please.
I would like to ask you something, please. I can't follow all your position and prestigious things, contributions. So please, for 2 minutes, present, because there are many young people. The old like me know you well, but there are younger colleagues. We count on them a lot to continue. So please introduce your kind self and your position.
Well, I think that this is not a question of curriculum. This is a question of concept ideas. I think that my focus today is to move from medical oncology and cancer treatment, that was my work through 40 years, to a more, I think, useful things for our community that are based in public policy and how the world will face the terrible tsunami that we are facing in health. It is very interesting to listen the speech from Mr. Trump yesterday, and one of the points of Mr. Trump was that there is a crisis in health that this is facing in a way. I am not telling that the way is correct, going out from the WHO and other things, but something is happening, and that is the reason because during the last years, I was doing my work at the UACC level, being president, but mainly having really partnerships and connection with people that is really taking the voice of the perhaps 80% of the world population that today has not access or the very poor access to health and cancer care. Thank you, Dr. El Sawawi.
Thank you. Your record after?
Please, the recording. Good afternoon, and thank you very much for your kind invitation, Professor ASCO-GOIS. I am Eduardo Casap, medical oncologist based in Buenos Aires, Argentina. I am very much interested in the point that you have raised about options or alternatives for prioritization or normatization of guidelines regarding options, alternatives for cancer patients in different parts of the world. You have mentioned some ones like choosing wisely, common sense oncology, or the case of stratified guidelines developed by Professor Ben Anderson. And I would like to share with you and the audience some of the basic points that for me are critical in this open discussion. I think that all type of recommendations, committee suggestion, prioritizations are documents, are norms, are guidelines, and that could or could not be followed by doctors. But I think that in most of the countries of the world and in most healthcare services and systems, the problem is not today based in guidelines. The problem today is based in access to care, continuity of care, of course, affordability of care, and the completion of the indicated treatment on time and following the best available guidance. So, saying this, I must underline the issue of doing more research in different healthcare systems in different countries about what happens after the medical indication or at the same time of the medical indication. Questions as, for example, is the doctor following some recommendation? Okay. If the doctor follows a recommendation, this following question is the patient following the recommendation? Is the system supporting the patient for the recommendation to be implemented on time and properly? Has the patient completed the treatment? And then, if we answer those questions, we will have a better idea not only about the recommendations, about the use in real time and real life of the recommendations, and with that, we can then plan estimations of results, monitoring, survival, curability, with a concrete and strong base. If not, in my view, until today we are having a theoretical discussion about all these options. Why? Because there are not, in general, evaluations about the how doctors are really doing the things in compliance with certain guidelines. We are not evaluating the continuity and the follow-up of patients at the healthcare systems and the necessary environment. I am not talking about money. I am not talking about what are or what is planned in the guideline. I am speaking about the evaluation of the compliance of such recommendations, the recommendation that You can choose any of them, choosing wisely, common sense, ASCO, ESMO, stratified guidelines, whatever. But we need to analyze how doctors react in the daily practice with guidelines, how patients are following or not the guidelines timely and properly, and how healthcare systems are really responding to this crucial need. So in summary, I recommend to increment the number of studies about the compliance of doctors with guidelines, the follow-up and monitoring of patients during the health system's continuity, and then to plan the best strategy in order to obtain the results that are more logical, efficient, useful, and realistic recommendations for different countries of the world. Thank you very much for your attention. Well,
thank you very much. Please introduce Professor David Kerr, and after Professor Enric. Okay, please, Eduardo, go on.
Yes, I don't know, Ahmed, there is a point that was raised through the chat. Do we answer this now or at the end of the presentations?
At the end, yes.
At the end, fantastic.
We consider all, and all please send us, even in the chat, their name and affiliation for the certificate after the fifth webinar.
Okay, fantastic. And now we have one of the most recognized experts in the field. Professor Enrique Soto Pérez de Celis is one of the leaders of the new generation of experts that is really doing a fantastic job in the field. And we will listen very carefully his opinions that are always very useful to all our community. Dr. Soto, please, your words.
Hi, Dr. Kassab, and thank you, Dr. El Zawawi, for the invitation. And as Dr. Kassab said, my name is Enrique Soto. I am the editor-in-chief of the eCancer Medical Science, which is the journal for eCancer, which is an online platform for oncology education globally. I also work as associate professor at the University of Colorado Medical School, but I'm originally from Mexico, so I've been working in the US since April. And today I'm going to talk about eCancer and how eCancer and the journal can support global oncology research. So eCancer, as I told you, is an online platform aimed at supporting oncology professionals through education. eCancer was founded by two amazing oncologists, Dr. Gordon McVie, who served as the director of eCancer until he passed, and Dr. Umberto Veronesi. And the idea was, in a way, to democratize the way in which oncology education is provided to people all around the world, and making sure that the best information and the most up-to-date information was available to everyone practicing oncology, regardless of where they live or how much money they had. Therefore, eCancer's mission is to improve care for patients with cancer across the world through education. And the fundamental belief of the organization is that the human right of every patient with cancer is to receive the best possible care, regardless of where they were born or where they are getting care. I think this aligns very nicely with what Dr. El Zawawi was saying at the beginning of this seminar. So the idea and what eCancer does is trying to remove the financial and geographical barriers healthcare professionals face when trying to access knowledge. We all know that getting to meetings, subscribing to up-to-date and things like that costs a lot of money, and some people cannot afford it. and therefore eCancer tries to remove those barriers and provide high-level education, ensuring through this education that every patient across the world receives the best possible care, and that the benefits from new discoveries and innovations are shared worldwide. And then supporting medical professionals learn new skills, update their knowledge, and improve the care that their patients are receiving. And I hope all of you are familiar with our website. And so what's the approach that eCancer utilizes? And I'm going to start here with the publications, because that's what I do. So we support the publication of research from low and middle income countries to our open access journal. I'm going to tell you a little bit about that. We then work with national and regional societies to develop guidelines and to develop ways in which to implement these publications, such as the Choosing Wisely initiatives across the world. We run face-to-face educational events based on guidelines and publications to support the effective use of new practices. And these guidelines have been done these meetings have been done all around the world: Latin America, Southeast Asia, Africa, India. And then these in-person meetings are developed into online resources, e-learning and video, that can support learners and reinforce a blended educational approach that mixes in-person with distance learning. And the final point, and what we all hope happens, is that healthcare workers can implement these clinical practices and then lead to improved patient care and further research. And the way in which eCancer does this is through 4 pillars. One is e-learning. So we have hundreds of online courses. Many of them provide CME credits. They're multidisciplinary. All of them are free of charge, and they're available in multiple languages. A lot of them in English, of course, but also in Spanish, French, etc. There is a video archive of interviews with key opinion leaders in the field. It is the largest library for cancer in the world. It gets about it has gotten over 20 million visits. So this is a huge library and a huge amount of information in there. As we talked about, we do events we support organizations in low and middle income countries to develop their events, have an amazing events team. We organize the Choosing Wisely initiative. And then we also provide tracking and coverage of cancer meetings worldwide. So eCancer is present at many meetings around the world, trying to find the research that can actually be translated into clinical practice worldwide. And finally, we have our journal. Our journal is fully open access. It has a huge editorial board of 138 members. We have over 50,000 PubMed downloads. It's indexed in Medline, and our most recent impact factor was 1.8. The journal's name, and I hope many of you have already published with us, and if you haven't, think about it. It's eCancer Medical Science, and this journal is free for those who do not have funding. It has a pay what you can afford model, in which people who have funding or who can afford to pay more, and people who develop their research without funding or are coming from a low-income country can publish without having to pay up a fee. We have a submission to acceptance period of about 130 days, which sounds like a lot, but I assure you it's not. It's relatively fast for many journals. We also offer free translations and editing services. We publish manuscripts in Spanish and in English, and we disseminate everything we publish through the eCancer website and through our social media channels. And there are a lot of links to illustrations and videos. It's a very flexible format, so you can include videos, illustrations, etc., without the limits that other journals may have. And over 600 authors from more than 30 low and middle income countries have published with us so far, and I hope that the next ones are listening to this presentation. We have some upcoming special issues, and these calls are gonna come out soon. So we hope that you'll be interested in this. We're gonna do an issue on reverse innovation in oncology, about cost-effective cancer screening tools in low and middle income countries, community-based care models, and reverse innovation in palliative care. So learning from what is being done in regions with limited resources to inform the care of patients worldwide. The importance of implementation science in global oncology cannot be overstated. how do we scale interventions in resource-limited settings, and how do we integrate global innovations into healthcare systems that may have limited resources. And then a very important point, artificial intelligence in oncology. I think this is part of the future. AI-driven personalized medicine, the ethical challenges, of course, of AI applications, and also thinking about how AI can help researchers in low and middle-income countries level the playing field with those in high-income countries. We, of course, face some barriers. There is an increasing proliferation of journals, many of which are led by huge editorial homes. The Lancet creates a new journal almost every day, and this makes it difficult to get high-quality content. And as you all know, as researchers in low and middle-income countries, we face barriers, have problems getting people who do appropriate statistics. There are language barriers and editing barriers. And we have some services to try to subside that problem, and the lack of reviewers. So I'll pitch it for everybody here. If you want to review for the journal, please send us an email at editor@ecancer.org so that you can become part of our reviewer pool. We're really looking for people who are enthusiastic about helping global oncology. So how can you participate with eCancer and with eCancer Medical Science? Become a member of eCancer, enjoy our online courses and interviews. There is a wealth of information there that's unmeasurable. Send us your research to the journal, and then you can also donate if it's something that you want to do. And eCancer belongs to all of us, to all the cancer workforce. That's the way it was envisioned, and that's the way we want to keep it. So thank you so much for your attention, and I'm really looking forward to your questions.
Thank you very
much.
Excuse me, Eduardo. Thank you very much because you who Eduardo. I thank you, Eduardo, because you who introduced to us Enric, and you also who I'm proud to be one of the associate editors of eCancer. This thanks to you, and we now count on a lot on eCancer as collaborator and on dissemination of our common message. This is not message of one group, but our common message, as we tell us always. So, Enric, please, you are one of the main pillars now of this initiative. This is your pillars, not this is your. I'm sorry, this is your initiative.
Well, no, I wouldn't say it's my initiative, right? I'm just, I'm just working on this now after Dr. Casap, who was a previous editor-in-chief. I'm very thankful for getting all the great work he did. But as you said, this is a global effort of hundreds of people, and looking forward to more people to join us.
Thank you. Be always together. Professor Eduardo Gazab, please.
Yes, thank you. And I think that the reason because we are so happy with Enrique is that we all have the same vision about how we need to move and try to improve healthcare systems and political aspect, economic components, and socio-cultural barriers for the future of healthcare. So thank you, Enrique, so much. Ahmed, our next speaker now is?
Professor Eduardo Gazab. It's Professor David Kerr.
David Kerr, okay. So now, according to the agenda, we will have also the presentation of one of the leaders, the global leaders in global cancer control, and a visionary expert from UK that understands very deeply the issues, the concerns, the barriers, and provide us with a clear vision for the future. Professor David Kerr is one of the more recognized global leaders in the field. Professor Kerr, we will have it in live or recorded?
It is a record.
Okay, so please.
He's now in his way to China.
Well, that is a good point because global means global.
Yes.
And global, it is not only the globality of interconnection or internet. Global in health is to consider all the large populations, India, China, Brazil, and other parts of the world that in only 10 countries comprises practically 70% of the world population. So we will have now the visionary presentation from Professor David Kerr, please.
Hello, I'm David Kerr, Professor of Cancer Medicine at the University of Oxford, which you can see behind me, the so-called Dreaming Spires. I apologise for not being with you live. I'm actually in the air on my way to China. We have a strong collaboration between Oxford and a number of leading Chinese medical schools, and they're very interested in developing relationships to see how we can improve cancer control and learn from each other. So, as you would imagine, an important meeting, but I apologise again for not being present, particularly to my dear friend Ahmed, who put so much of himself into organising these fantastic seminars. Let me thank you all for joining. This is our third such seminar, and again, thanks to our friends and colleagues in ASCO for coming with us in terms of helping to provide support for all of you. The title of the webinar today is an overview on scientific, resource-saving and better value cancer treatment approaches. This is something which is dear to the heart of Ahmed, myself, and many of the senior colleagues who are gathered around the table today. And I guess what we would like to do is to encourage each of you to be game changers and to work with us. The messages that we hear today, the fantastic colleagues that we have who will be lecturing, we would like to share the ideas and concepts that we develop together as widely as possible within your own networks, and of course provide your own feedback. There's nothing better than us working with you, getting you an idea so that we can work together to disseminate and to move these forward. We've discussed before the concept of better value healthcare, specifically better value cancer care. And better value does not mean inferior. It means that we deliver the best we can in resource-limited settings using rational, intellectual tools and evidence. The evidence that we would apply to any randomized trial of a novel therapy, if we're bringing new radiotherapeutic regimes, schedules, novel targeted drugs, the evidence underpinning our ideas around better value cancer care are equally as strong. So, welcome to this third in the series of these important webinars. We'll be announcing number 4 and 5 soon. And again, of course, we invite you to join these too. And Ahmed and I again share, it's interesting, being that tiny bit older, all of the young clinician scientists listening today are brought up in molecular biology and molecular genetics, on understanding in detail some of the cellular pathways that are involved in driving carcinogenesis. When we started off in medical oncology, clinical pharmacology was equally as important. Understanding not only the pharmacodynamics, what the drug does to the body, but the pharmacology and pharmacokinetics of what the body does to the drug. And it's very interesting how we can be guided by good old clinical pharmacology, which isn't as well taught in medical schools as it once was. So we'll spread the net wide in terms of our intellectualization, in terms of us wanting to build ideas forward. Again, sorry I can't be with you. I really enjoy these webinars. I enjoy the quality of the speakers, Ahmed's indefatigable enthusiasm, which is his hallmark and his characteristic, if you like. I know that it will go well. We will be, for those who attend, we'll be signing certificates of attendance and making these available soon. I promise that. But again, work with us, contribute your ideas, your own thoughts, and we look forward to that. Thank you very much indeed again for attending. And in our next webinar, I hope to see you then. Thank you very much.
Thank you very much, Eduardo. Please introduce me now. I am the next. It is record. Yes, Eduardo. Yes, I am the. Please introduce me now. I have the honor that will be introduced by you.
Yes. I am sorry, I had some interruption here in the
No problem. Just
in
introduce
the
me and there is record. No problem. It will go.
yes, yes. Give me 1 second. The next speaker is
Me.
a new and young resident in oncology. Well, as you know, our leader in this endeavor is somebody that is pushing for a better really access and care for many patients and healthy populations, because I know that there are several questions related with prevention that at the end of this webinar we will discuss if possible. And Professor El Sawawi is one of the founders of several international organizations from his home city, Port Said in Egypt, and is also one of the facilitators of many actions between Africa and Europe or other parts of the world, and is the alma mater of the Win-Win Initiative and also the Harvard participation with Win-Win and many others developments all over the world. So, Professor El Sawawi, please, can we see your recording?
Thank you very much. And please be patient with my recording because it is slightly long, but it is summarize many initiatives in the world. We are not speaking about mine or our friends or our groups, but we give an idea of what is going on in the world. Some examples, there are a lot of examples. Multiple drugs instead of chemotherapy with one drug. Hello, I am very pleased to be among you today. We are in the ASCO-GOIS international webinars. ASCO is American Society of Clinical Oncology. GOIS is Global Oncology Implementing Science Program. It's a part of GOU. The program, this program is entitled Be Game Changers in Global Oncology. And it's really, the change is very needed. The focus of the 3 webinars is on how, via scientific approaches, to lower the total cost of systemic therapy without compromising the outcome on patients. And this is, again, this is the whole, maybe, core of the Win-Win Initiative. But not only for systemic therapy, but for cancer care in general and cancer control. Title of the third webinar, an overview on scientific resource saving and better value cancer treatment approaches. The title of the 4th and 5th webinar will be the upcoming webinars. Next month, it will be examples of scientific exploration for research saving better value cancer drugs or systemic therapy. I know that the 4th and 5th webinar will be enjoyable because there are many pharmacology, many examples of clinical work, and many publication about this. But this third webinar is very important because it is it shows this. If we would like really to be game changers in global oncology, we should be aware of and critical view, also in constructive critical view, most of the ongoing initiative and englobe all together. And we very open to any initiative that serve the goal. As we say always, the win-win belongs to all. It belongs to you, and will be it is win-win. An overview on scientific resource saving and better value cancer treatment approaches by Professor Ahmed Zawawi, Chair of Win-Win Initiative, Chair Board of Directors of Global Oncology University, the GOIS, and founder, President of ICDOC, Experts in Cancer Without Borders, and past President of Aortic African Organization for Research and Training in Cancer, Professor of Clinical Oncology at Scandinavian University, Ismailia, and Chairman of Al Suleiman Radiation Oncology, Port Said, Egypt. But this based on chapter 14 that and we have the links of everything of the full program, and we are stimulating brainstorming issue. We don't claim that we have the completely perfect statement or complete truth. Science is perpetual searching forever. So leave recorded panels or organized, including this webinar, as part of this program. They are open for all views. This could enrich science and the cause of cancer care. All your feedback, comments, and suggestions and constructive critics are welcome. This disclosure of interest, none. And I would like to say that if I say this communication is by me, but presented by me, but I inspired from the work with distinguished colleagues. It's not inspired, really. International organization, and I work in many international organizations and society in the world, in committees as advisor, expert, and chair for along the last 35 years. You notice that most of our slides as the text is not short, not with few words or slides, because what present is summary, but as much as possible we add some reference is intentionally to be used as PDF material or for all who would like to receive the copy. So the full text of the slides is between you and that. If you can ask for it, we can send it to you. As we agree together in the Win-Win Initiative, we adopt this flexibility of thought, a free flow idea, classic and innovative approach. The objective in this third ASCO-GOIS International Webinar, we present some example of prominent initiatives. But there are many initiatives in the world. The Win-Win International Initiative, the total cost and not solely the prices of, we stress on that, and not only the price of drugs or devices or intervention. Personalized cancer medicine and better value outcome on patients, using wisely campaign, financial toxicity tumor board, common sense oncology is very important. Also, and Bishal presented that in our GOIS program, a nice communication about common sense oncology, which is very important in the last webinar. Encouraging probable futuristic approach, reducing the cost of care via a redesign of health. Reminder that the two wings of the Win-Win international scientific initiative are to increase affordability of better value cancer care in the world via scientific approach, education, studies. That is why we are doing what is the things, education, studies, and research, and win-win models that consider the interest of all stakeholders. All will win. Second thing is to increase the number of quality of cancer services in the world via catalyst action. We don't claim that we do all. No, to catalyst action and relevant collaboration, cooperation always, and relevant education and training. The goal on how to enhance human capacity and resources, and said adopt and lead scientific approach to increase affordability of triple value of cancer care. What is triple value of cancer care? The patients, the community, and science. For millions of cancer patients in the world with dignity. and not just the usual ready-made program stereotype repeated curriculum. And the global oncology implementing science, part of GOIS. The win-win movement introduced modestly by me in December 2007, but I don't claim that I am the inventor. This is after inspiring and consultation with many experts and stakeholders and even industry in the world. We don't seek for praise, but the glory is for the real doers, and particularly the locals everywhere in the world. In the real world, why it is win-win? Because the interest and the incentive of all stakeholders should be considered to be realistic. Incentive and remuneration of professional cancer care are mandatory, should be considered as and repaired. Otherwise, the different ways of corruption under different name or abuse of resources or commission or percentage or whatever, it happens in most countries, even my country, surely, in different parts of the world. Will continue. It's going to continue if we could not consider well the cancer care professional as one important element of all this initiative. All will win. It is not unrealistic or romantic, but it needs smart and innovative, scientific focused approaches and broad scope and intelligent deals. Even the industries will flourish more, because otherwise it will be not realistic and enormously increase their markets. Many markets could be open. There are many dead markets or weak markets. There is need to change the game of global cancer care, and for a think tank that like what proposed by President Roosevelt for the New Deal. We have a component here. We start with a win-win initiative, as we give you a hint about it, but you know many about it. The win-win initiative suggests the clinical oncologist shouldn't copy protocols or guidelines of international societies or group automatically. They don't feel fit the local patient and condition. For example, by definition, the cancer treatment guideline could be very useful as guides, but not obligatory considered as pathways to treat certain patient in front of you, which is maybe different from the next patient in front of you. And this means that there is wide gate for scientific works and relevant publication for the real world practice. We mean the total cost and not solely price of drugs or device per se. However, in the last year, there is more skyrocketing increased prices of new drugs than ever. We in the win-win movement stress on that the value of intervention and treatment should be patient-centered and also varies at different communities and conditions. We stress on that the win-win movement we mean by scientific study, not only medical, but clinical, pharmacological, medical physics, innovation in health industry, and informatics studies. And also economic research, business model studies is very, very important. And all aspects that contribute to increase access to better value cancer care in the world. In the win-win movement, we adopt the notion that inspiring from measures or experience of some countries could be useful in others, even from rich country to poor country or that country, provided from poor country to rich country. Yes, it's possible, provided it should be applied in a smart and scientific way to adopt or modify only or to modify only the measures that could fit the specific countries. Personalized cancer medicine and better value patient in 2011. I presented that there should be a broader measuring term of personalized medicine, proposed that the term personalized treatment would dispatch from the notion of only hitting one target on the tumor by a drug, usually expensive, to the broader concept to consider medical factor, biological factor, which is very important, but should be effective. And by condition, it could be quite effective. and human factor as personal expectation and priorities without compromising the overall outcome via evidence-based studies. I present also in the book Better Value Cancer Care, led by Professor David Kerr and Professor Seymour Gray, and also Professor Eduardo Gazab hold decision I participated and presented in ESMO 2014. It should include prediction of risk and toxicity of treatment in the real daily practice in the real world. This is also we add. Choosing wisely in medical practice is very important initiative. Over-treatment and unnecessary care and the consequences for patient safety and health system and sustainability are issue of increasing concern. The Choosing Wisely campaign became international multidisciplinary initiative. More than 80 professional studies, societies, and even increased now, have participated in the effort, generating a list of more than 800 examples of unnecessary and low-value service, and is increasing. The Win-Win Movement comment, our comment that it's great appreciation for the huge international work of the Choosing Wisely and collaboration, but there are limitations. We should explore all. Choosing wisely medical practice over the cost of cancer care is augmenting exponentially. It become now 173 billions in 22, and now it's more in 2025. And 21% at least of this cost is money spent is unnecessary according to publications. You can view the web Choosing Wisely. This is their web, and there are many examples led really by Professor the great professor that I appreciate very much, Professor Lewel Schneeber, United States. American Society of Clinical Oncology declares the Choosing Wisely top 5 list. However, ASCO also stated that the items are provided solely for informational purposes and not intended to replace a medical professional independent judgment or a substitute for consultation with a medical professional. It's very important. For example, don't use a combination chemotherapy, multiple drugs instead of chemotherapy with one drug when treating the individual, instead of chemotherapy with one drug when treating an individual for metastatic breast cancer, unless the patient needs a rapid response to relieve tumor or related symptoms. This is a condition. Avoid using PET-CT scanning as part of routine follow-up, many frequent for PET-CT, to monitor the cancer recurrence of asymptomatic patients who have finished initial treatment to eliminate the cancer, unless there is a high level of evidence that such imaging will change the outcome. This happens everywhere, unfortunately, even in my country. Many don't perform PSA testing for prostate cancer screening in men with no symptoms of the disease when they are expected to live less than 10 years. Don't use targeted therapy intended to use against genetic aberration unless the patient tumor cells have a specific biomarker that predict an effective response, quite effective response to targeted therapy. Recognize limitation. This is a very great Nobel initiative, but there are some limitations as anything in the world. No doubt there is a great need in all over the world to achieve the aim of choosing wisely. But however, the campaign has garnered both praise and critics, constructive critics, and some of the ideas have spread to other countries. In a study done in 2015 in USA, primary health caregiver found most Choosing Wisely recommendations easy to follow, but they feel that some, especially those for symptomatic condition, would be difficult to patient to accept. Some doctors said that they lack time for the recommended discussions, and this sometimes is not so easy. Mostly not so easy. In UK, English doctors are worried how patients will perceive the initiative. Choosing wisely recommendation should not be used to establish a coverage decision or exclusions. This is according to ASCO. And ASCO said that it is but they meant to encourage conversations about what appropriate and necessary treatment, as each patient's situation is unique. Is according to ASCO, and this is reference here. Regarding the impact, one should note regarding the impact, one of the noted critics is that choosing wisely does not include evaluation of the effect on cost or discussion on medical outcomes. The choosing wisely campaign has no anticipation to scientifically research its own efficacy, but academic centers and clinics are making plans to independently report on the impact of the campaign. Doctor analyzed many services listed as low value by choosing wisely, and other sources and found that 25 to 42% of the Medicaid patients in the United States received at least one of these services in average year. The scope of choosing wisely recommendation for cancer care is not well defined. This quality movement improvement still characterize the scope of this recommendation, focusing on the de-implantation of low-value cancer care, identify potential challenges or different views for future work. There are more potential defects in choosing wisely initiative, perhaps the major, the lack of uniform metrics. It is feasible to state that the test is unnecessary, but what criteria are used to reliably and prospectively define what is necessary? The most important challenge will be the change of our attitude in clinical practice for the situation in which scientific evidence suggests that the proposed intervention has modest or no impact or could be harmful. Should be scientific evidence. The change is necessary, and this change is necessary, and the challenge should be accepted quickly, so that choosing wisely more and more will mean choosing right. It was reported that several important steps still remain to fulfill the promise, and choosing wisely is now time to take those steps. As we in the program adopted flexibility of thoughts and encouraged brainstorming idea, we may suggest that the choosing wisely campaign adopts the notion of the win-win initiative, which belongs to all. It could be advocate for global collaboration partnership to conduct unlimited scientific exploration and of evidence and value-based and patient-centered innovative approaches. That the rest of different parties and scientific evidence would be considered. Hence, it would be a global scientific better value choosing wisely campaign with other many good initiatives. We'll present some examples today, where all stakeholder cancer care in the real world would gain, particularly in cancer patients. Then, the initiative Financial Toxicity Tumor Board. The fiscal distress or what it is financial toxicity, in which patients experience challenge in paying for treatment, are becoming dominant problems for patients with cancer globally. For that reason, the first Financial Toxicity Tumor Board was launched in September 2029 in the Leuven Cancer Institute. This institute consists of more than 40 hospitals and 900 offices that provide more than 12 million encouraged per year. This is in North Carolina and South Carolina and in Georgia. This model is modeled on the concept of a conventional multidisciplinary tumor board with participation, but with participation not only with physicians, but nurses, financial counselor, nurse navigator, social workers, administrator who meets monthly. They are focused on financial toxicity and financial worry and fear experienced by patients with cancer. As a result, they found that around 60 million of personal expenditure has been evaded for nearly 1,800 patients. It's very interesting. Common sense oncology is very interesting and very respectable objective. It's a group of international experts and distinguished oncologists published a proposal that the win-win consider with great appreciation. It's intentioned common sense oncology. Several distinguished colleagues, really, Richard Sullivan, Booth, Christopher Booth, Bishal, who presented a nice hint about it in the previous ASCO-GOIS webinar, David Coloningridge, and many distinguished really colleagues, dear colleagues. It says that oncology needs a recalibrated approach that is more patient-centered and prioritize equitable cancer care. An approach that prioritizes patient needs with treatments that improve survival and quality of life. It promote informed decision making, and ensures that the treatment are accessible to all patients. There is a reference for this. With appreciation for to noble initiative by distinguished experts and colleagues, understanding of the common goal of the all similar good initiative, we in the win-win, every effort should be done not to consider the issue as a challenge or balance between innovation and access to cancer care, or innovation between hype, what's called hype, and what we have. But science should work to implement and to make things more affordable. It is not against, but with the affordability. It should be used, how to use it intelligently with increased affordability. In the win-win movement, we see that there is a need for big and wide movement of innovation and implementing science of more focus to increase access and better value cancer center care, and for the people of good, all will win. It is feasible. We presented many examples, but there are a space for a place, ample place for a limited number of research and studies really by all. What we see is, despite as many examples published and in our previous courses and in the upcoming seminars also, encouraging a portable, we didn't invent anything. This is published and evidence-based by many authors. We didn't invent anything. It's encouraging futuristic approaches. An example of is genomic adjusted radiation dose. A new proposal to integrate genomics into radiation dosing decision. Hence, what's called GARD, based on framework, who could be the new model for personalizing radiotherapy prescription dose in clinical practice. Till present, as we all notice, radiotherapy drops behind the vast progress done in targeted agent in systemic cancer therapy. In our view, we see that in spite of these tests could be expensive and that surely need advanced technology. However, with well-planned inter-institutional and industrial cooperation, this could be more developed and used widely in the West. Hence, it could be after, for it would be with organized and focused North-South cooperation. This test could be applied in the South. This is surely for future studies. Reducing the cost of health care entails care design. New England Journal of Medicine, Catalyst Insight Council member discussed initiative for decreasing healthcare costs, such as healthcare transition and home-based care model. So healthcare redesign and include many things. It's very really important. All the above recommendations and suggestions are important. But we see that according to the win-win notion, without focused scientific study and exploration and clinical research, most of the recommendations would remain plans or wishes or in conference application and initiatives, just initiatives. The win-win scientific initiative raised the warning sign that most, if not all, economic system will not cope well or will not cope at all with the skyrocketing rise of total cost of cancer care. Hence, there are increasing of upcoming collapse or failure to cope. So it needs collaboration, cooperation with all. Many combined scientific work are needed, and there are already many examples in next fourth and fifth webinars for systemic therapy, and after for radiotherapy. There are at least 5 webinars in our books and reference and everything. It's time to move. Final notes and reflections. It's time to move from choosing wisely to choosing right, or as Lister suggested, using wisely, using and not choosing, with the increase or at least to keep the value of cancer care through clinical research. Within scientific win-win scenario, smart idea, and every effort should be paid to consider the interest of different stakeholders. Hence, all would win in the real world. Please allow me to share with you my brainstorming points for wide feedback and for and to be included in the upcoming panels and for your discussion now and after. We welcome all your feedback sent to us, and we include this in the by your name and affiliation, everything. We are open for all constructive criticism, comments, and suggestions. In our view, choosing wisely common sense oncology or recommendation committees, commission publication, or stratified resource guideline aimed at prioritization of treatment according to what could be afforded or what makes sense, or according to the survey for wise intervention, those are not strictly applied by the surveyed consultant themselves in their daily practice. Or that is what Professor Eduardo Gazab will present, and he will present after in CCGA study, and present today something about this. Important, very important. All that are surely very noble initiative, but on the other hand, many circumstances they could be considered as acceptance of situations that should be changed for the better of patient. Just acceptance of the situation. It is not more scientific and logic to first focus on scientific efforts on detecting a lot of already published alternative of treatment without compromising the outcome of patient, and to increase enormously all scientific efforts for innovative approaches, smart model, and win-win deals. Therefore, we in the win-win movement and in this GOIS program and our books are considering with appreciation the using wisely common sense oncology, financial toxicity, tumors boards, and all similar very needed endeavors. Moreover, we are calling for enhancing proposal, initiative, constructive endeavor by collaboration, cooperation, coordination, and evidence-based and pragmatic approaches that consider wide feasibility in the real world. Otherwise, the affordability of cancer care, including the rich country and healthy country, will have increasing crisis now and in the future. Could we come together to conclusions that the goal of increasing affordability of better care is a very important thing, a very important issue. There are published and our work to solve it, not to speak about it. There are many talks about affordability, about the disparities, but what is our role as scientists, as doctors, as clinicians, as thinker, maybe, to change the game, and not to just to complain all the time. You see in our previous programs and in the upcoming program, many examples, really evidence-based, and they can do a lot. Many evidence-based examples, and this open a way for a limited number of researches. There are published suggestions that whole burden of discussion. Some suggest this, and this is that the whole burden of discussion with patient about the cost of treatment should be upon the treating cancer care doctor. No, as a clinician, as a researcher, I see this is not fair. It is unfair. It is very hard or to put everything on the shoulder of the treating doctor, or even cruel to discuss as a doctor with our patient that the cost of suggested for cancer care is high than he or she can afford. We choose wisely or follow, or that we will choose wisely or follow the sense. How can faced as a father
or mother or wife, husband, telling that cancer care of their beloved person is not affordable to them, or to choose other less costly care without scientific evidence that is not less patient-centered outcome and value. This need a lot of scientific work, and it is feasible. Isn't better that we as cancer caregiver and scientific and medical communities do first an effort to finding this our role as much as we can, scientifically acceptable and published alternatives. There are many things published really without compromising the outcome of patient. Then we call our wisdom after and sense and not before. How some scientific work or presentation undermine understanding of global oncology to prioritize deliver radiotherapy in countries where there are no adequate facility according to the rate of expected survival of cancer. If he live long, that they can give him treatment and let him screaming. How could we recommend the treating oncologist is not to deliver palliative radiotherapy as soon as possible to cancer patient with severe pain of bone metastasis, for example, impending fracture, impending spinal cord, or medial compression, because he is very late? There are some suggestions like this. Because it is far, because no, do something, do one fraction, big fraction. There are many solutions. While there are many scientific approaches at present, now is now to double or even triple the number of treated patients with existing radiotherapy facility in most of countries who haven't adequate number of services. It is published by many distinguished colleagues, and we include this in our books. We presented this before. We published this, and there are upcoming seminars also again about radiation oncology for longer term. But starting from now, to plan to increase expansion of delivering clinical oncology with different acceptable but scientific model in the real world. We mean remarkable expansion and not too much noise. And festival, radiotherapy festival, awareness of radiotherapy for cancer, something for yearly 0 to 3 more departments or one center of excellence here and there. But for in the underserved region, in considerable part of the world, while what is needed is at least 10,000 clinical oncology service. This short of that. Of this time, maybe and will increase. So it's not 1 or 2, 3, 4, 10 centers here and there, and charity by the year or international organization, and all this what is center of excellence, but it's 1 or 2 or 10 center even. We don't claim that we have the completely perfect statement or complete truth. Science is perpetual searching forever. So live recorded panel are organized as part of the program. We are open for all views. This could enrich science and the cause of cancer care. All feedbacks, addition, comments, advice, constructive, critics, and new suggestions are welcome. We don't claim at all that we have the full wisdom. We don't claim at all that we have the magic stick, but together we can do a lot. Via science. If you like to get a PDF copy of the slide, please feel free to send us. And thank you for cooperation, and please feel free to send us your feedback.
Thank you very much for your excellent review, Professor El-Sawawi. I think that now we have more ideas and matters to add to the debate. So thank you. And now our following presentation is Dr. Carol Sikora. Professor Sikora is a leading world authority on cancer, and he is currently professor of medicine at the University of Buckingham. And he has, of course, many other positions, not only in the UK, but also as director at the Bahamas Cancer Center, between many other positions. So please, Professor Sikora, you have the floor.
Before
Yes, of course.
introducing my dear old friend Kirill Sikora, who is among us today also, and he's one of the leaders of this initiative. But we should listen to the different aspects. Professor David Sikora gives some realistic thing about what is going on, and I think that uh, our role is to not accept the reality as it is, but to change the reality. This is our role. We listen together and we discuss together. Professor Kirill Sikora.
Hello, my name is Carol Sikora. I've been in oncology for nearly 50 years. I'm head of Imperial College London's oncology department, providing services for West London. I spent 2 years with the WHO running the cancer program. So this is a great initiative. The trouble is, nothing's for free out there in cancer. Drugs are becoming increasingly expensive, radiotherapy increasingly sophisticated and also expensive, both the capital costs and the maintenance costs and the skills of the IT people, the computer people that make it all work. So, in any economic environment, the treatments available have to be tailored in a sustainable way to the resources available. There's no point starting CAR teeth programs in a country with a GDP of less than a reasonable amount. It's just not doable. Similarly, the very latest proton machine costing $30 million is not feasible for people that are earning $10 a day. There's nothing you can do. Even Ahmed's best wishes and his enthusiasm is not going to magic treatments that are expensive for people that are poor. I think as physicians, we tend all to be a little bit socialistic. We like the idea that everyone gets the same treatment. But that's not realistic in the world out there. Rich people will always get better care. One of the problems in some countries is that at least 5% of the population have enough wealth to buy themselves out of any healthcare system that's provided for them by the state. They can buy it by going privately in their own country, or even if they're very well off, to go abroad. Very expensive to come to London, to go to Paris, to go to Frankfurt, the European centres of excellence, or even to Memorial in the States or to MD Anderson, which welcome these people, but they're not representative. And I think the first thing we have to do in trying to improve things around the world, the so-called win-win initiative, is not worry about the fact that the rich will always get better care than the poor. We can't fight that. What we can do is make sure that the poor get decent basic care that's efficient. It doesn't consume resources that are low priority, but instead provides the sort of thing, pretty obvious, decent radiotherapy, hypofractionated to reduce the demand on the capital cost of resources. More patients can come through with hypofractionation, 5 fractions for breast, 5 fractions for prostate, and then a whole range of other hypofractionation schemes. We also have to have palliative radiotherapy, single fractions for bone metastases, very effective. And then with chemotherapy, we have to prioritize it. The most important, of course, are the curable diseases, such as testicular cancer, lymphomas, and germ cell tumors of all sorts, and a range of other cancers where adjuvant chemotherapies have proven value, breast and colon, for example. And of course, with breast cancer and prostate cancer, hormonal treatment, generics are cheap. The problem is the pharma industry want to push things. They want to push immunotherapy. Just not possible in a poor country. It's $10,000 a month, for goodness sake. It can't be done. And there's no point fighting it. And the gains are not as big as the adverts would suggest. That's the problem. So in the win-win initiative, what we've got to do is have realistic therapies, both radio and chemo, together with good palliative care, that's cost effective. And that's the only way we can win in this business. And we as doctors have to campaign for not the latest and newest and most expensive of treatments to be available for everybody, but for decent basic care, and to prioritize things like pediatric cancer, which are mainly curable, and diseases where we do have a high response rate and a high cure rate. It's a challenge. The patients read the press tell them, press releases are coming out from industry, even from politicians, governments, that they're putting the latest in, magic tests that detect cancer. A lot of it is just rubbish, and it's there to raise money for biotech companies, pharma companies, and so on. But it's not part of the way in which we should be delivering healthcare. We've got to have a strategy that prioritizes the successful over the unsuccessful. So I hope this initiative is tremendous, but I think we keep repeating ourselves. And what we've got to do is just use our knowledge to get good basic care to as many people as possible out there. Thank you.
Can you allow me, Eduardo, to add a comment?
Please. Yes.
Dear Carol, you are among us. We are not repeating ourselves. There are many examples, limited numbers, very exciting. Look for the next fourth and fifth webinars. There are many examples. There are at least 5 webinars about radiation oncology after, and we need your leadership in it. There are many things, there are many ideas, but to repeat the same thing, we are not repeating the same thing. There are a limited gate, or very open gate for many research and studies based on what existed now, and nobody listened. So there are many solutions, and we need your criticism and your pushing forward for how to lower the total cost without compromising the outcome. Is not giving something few treatment for the poor and higher treatment for the upper, and this is to say this is stratified. No, it is not us as a doctor. This is not our role at all.
Well, thank you so much.
Carol was asked, by the way.
We are a little bit short of time, so we will move to our next presentation. Our next presenter is also a global leader, Professor Hussein Khaled, former Minister of Education in his country, is dean or was dean of the National Cancer Institute 2002-2008, vice president of Cairo University, and many others positions, relevant positions in Egypt. And he is a great educator and a global leader in health. Please, can we have the presentation of Professor Khaled?
My name is Hussein Khaled. I am a professor of medical oncology at the National Cancer Institute of Cairo University in Egypt, and I served as a member of the UICC Board of Directors during the years 2016 to 2018. How can we recognize and address cancer as a major global health concern that is severely straining health systems? And how can we address the increase in the gap between the required and the affordable better cancer care? In the year 2012, the United Nations General Assembly has adopted a slogan that said to decrease the deaths from non-communicable diseases, including cancer, by 25% in the year 2025. And then, feeling that they will not achieve this goal, the slogan changed it to reduce by 1/3 the mortality of non-communicable diseases, including cancer, by the year 2030. And they put 9 targets to achieve this important goal. Did we achieve this goal? I think if we look to the numbers and we see the time trend analysis of age standardized incidence rates between the years 2012 to 2022, there is an percent increase in this incidence rate by 8.2% globally. And this was, if you divide it, there was a decrease by 3.6 in US, decrease by 2.7% in Europe, and also increase in the incidence rate by 39% in Africa. In addition, if we look to the age standardized mortality rate, we will see that there is globally a percent decrease in this rate by 10%. This rose to 13.6 in US and to 7.3 in Western Europe, and on the contrary, increase in the age standardized mortality rate by 13.7% in Africa. So did we achieve this goal? The answer is clearly no. At the same time, what is the time trend increase in the cost of cancer drugs? If you look to the data from IQVIA, we said that we see that in the year 2019, the total cost of cancer drugs in the year 2019 was 148 billion US dollars, and this number increased to 255 in the year 2024, and it is expected to reach for more than 400 billion US dollars in the year 2028. Astonishingly, and in one article from Sweden, the cancer drug reimbursed with limited evidence on overall survival and the quality of life was published. And the study included many diseases, many cancer diseases: renal cell carcinoma, non-small cell lung cancer, breast cancer, ovarian cancer, melanoma, Hodgkin lymphoma, and so on. And astonishingly, there was 68% no evidence of improvement by these drugs regarding the overall survival nor the quality of life. So what is the way forward? The way forward is to invite the governments to apply precision cancer control planning, improve data acquisition and cancer registry, especially in low-middle income countries, design healthcare systems that promote equity and access, increase cure and improving care, effective palliation, building and maintaining the health infrastructure workforce, innovation and research, and more importantly, investment in telehealth. By this, I thank you for your attention, and I hope that we could achieve this goal in the future.
Can I give a comment, just a comment? At the end, we will have you, Professor Eduardo Gazab, generously will lead the conclusion remark and discussion with Professor Kiro Sikora and Abba Maloum and Professor Nabil Mubarak. This is the last 10 minutes. Now, introduce Jack after. Jack. نتكلم دكتور كذا. مش okay. You were saying something because you are making mute, Eduardo Gazap.
I am sorry. I was saying that now the next presentation
Yes.
is from Professor Jakes Bensudenhout. He's from Stellenbosch University School of Science and Technology. He's a world leader in diverse areas of radiotherapy, radiation protection, nuclear science, and other aspects, even inclusive environmental chemistry. So please, can we have the presentation of him?
Good day, I'm Dr. Jacques Besaidenout. I'm a radiation oncologist currently working in Brussels in Belgium, but I'm originally from South Africa, and due to this background, I've always had a keen interest in global oncology. Today I'll say some words on scientific resource saving and better value cancer treatment approaches. As an introduction, worldwide the total costs of cancer care are increasing steeply, raising important questions on the sustainability of cancer healthcare systems, not only in low and middle income countries, but increasingly also in high income countries. This is partly driven by the increasing costs of oncology drugs. Global spending on oncology drugs was 223 billion US dollars in 2023, and this is expected to reach more than 400 billion US dollars by 2028 with no end in sight. As countries struggle to pay for and access oncology drugs, there is a growing disconnect between the price, affordability, and the value of these drugs. Of the 129 cancer drug indication pairs granted accelerated approval by the regulatory agency in the United States between 2013 and 2023, 41% did not improve overall survival or quality of life in confirmatory trials with longer follow-up, raising important questions on the intrinsic value of these drugs. Furthermore, these increases in spending on oncology drugs could lead to less money being available to invest in other core pillars of cancer care, such as surgery, pathology, and radiotherapy. Given these rising costs, there have been numerous calls to provide cost-effective and value-based treatment alternatives tailored to patients in different disease and income contexts. As an example, the Choosing Wisely campaign was initiated by the American Board of Internal Medicine Foundation to promote discussions about evidence-based care to eventually reduce the use of low-value procedures and treatment. Recommendations specific to oncology were added to the Choosing Wisely campaign by the American Society for Clinical Oncology. More recently, the Common Sense Oncology movement was launched with the vision that patients have access to cancer treatments that provide meaningful improvements in outcomes that matter, irrespective of where they live. One of the win-win scientific initiative's goals is to increase the affordability of better value cancer care in the world via scientific approaches, education, studies, and win-win models that consider the interests of all stakeholders. From the issues addressed above, it becomes evident that value needs to play an increasingly important role in cancer care and especially in cancer treatment. Already in 2013, Sir Gray and Professor David Kerr stated that value will actually be the predominant term for the upcoming years. It also needs to be stressed that to achieve affordable cancer care, there has to be a focus on the total costs and not the price of any individual drug per se. It is estimated that cancer drugs only constitute 10 to 30% of the total cost of cancer care. Value in cancer treatment and care. Porter and Theisberg defined value as health outcomes achieved per dollar spent. Value therefore depends on results, so value in healthcare is measured by outcomes achieved. To incorporate the issues of overuse, underuse, and inequity, three aspects of value were described by Sir Gray and Professor Kerr. These aspects are allocative value, determined by how the assets are distributed to different subgroups in the population, technical value, determined by how well resources are used for all the people in need in the population, and personalized value, determined by how well the decisions relate to the values of each individual. And these three aspects of value constitute the triple value healthcare model. Several value frameworks are currently employed in cancer care. These include the Value Assessment Framework of the Institute for Clinical and Economic Review, ASCO's Value Framework, and the European Society for Medical Oncology's Magnitude of Clinical Benefit Scale. Every effort should be made to reduce the gap between cancer care costs and cancer care outcomes. According to the notion of the win-win movement, the number of cancer services should not be counted as a final objective, but rather the affordability of better value cancer treatment and care. It is important to keep in mind that there could be resistance to adopting the concept of value in order to save resources, mainly due to potential conflicts of interest. The Win-Win Initiative stresses the importance of cooperation in a broad global campaign to promote scientific value-based research and implementation, and to convince all involved stakeholders of the importance of value in cancer treatment and care. In achieving this, all parties would win, and the sustainability of the health system itself would be safeguarded. As a conclusion, cancer treatment and care based on the triple value model, including allocative value, technical value, and personalized value, could be an important instrument to increase the affordability of cancer care across countries with different income levels. It is paramount that the endeavors need to be scientifically rooted, and furthermore, the interests of all stakeholders need to be considered in order for the endeavors to be win-win initiatives.
Excellent.
These
Thank you very much.
references.
Okay, Susie after.
Yes, this was, I think, a great presentation with an innovative strategy using a model in order to analyze the question. I think that now we have, last but not least, the final presentation. Susan Staway is leading one of the innovative approaches for the dissemination of knowledge of new information, innovative strategies. She is the leader of the London Global Cancer Week in the UK, an initiative that is growing very well, and now it has a branch in Latin America. It's the Latin American Cancer Week, and we estimate that there will be soon in an Asian Cancer Week as well. So please, can we have the presentation from Dr. Steinway?
Thank you very much, Ahmed, for asking me to say a few words at this ASCO-GOIS webinar. My name is Susie Stanway and I'm a medical oncologist based in the UK with an interest in global cancer control and also a serving member of the International Affairs Committee of ASCO. So when we talk about global cancer control, really what we mean is evidence-based, accessible cancer care of value across the continuum for all, irrespective of geography or income level. So when we talk about global cancer control, really what we mean is evidence-based, accessible cancer care of value across the continuum. And this is going to be an endeavour that requires all of us around the world in our different countries to collaborate with each other. So as the global cancer community, why should we work together? Well, this is because solutions are going to be found by multidisciplinary teams working towards political, social and economic transformations. This is going to mean that we're more efficient, it reduces duplication of work, and there's going to be multi-directional sharing of good practice. And importantly, I think that by coming together, we're going to amplify a united voice. And this is going to be an So this endeavour is going to need many things. So to build on these successes will here at the top. So there's room for everybody to contribute to reducing inequities, whether this is reducing inequities within our individual countries or between countries. And this is going to require education, it's going to require research, capacity building, allyship, convening, networking, mentoring, advocacy, policy, and this is by no means an exhaustive list, but I've started putting down some items just so that everybody realises that you can get involved in whatever way you can. So there's room for everybody to contribute. So London Global Cancer Week will run for the 7th year this year. It's a series of over 40 curated meetings that are multidisciplinary, international, and hopefully span the cancer continuum. It's free to host, free to attend, and the meetings are recorded such that people can access them retrospectively for free on our website. Please see the QR code here if you're interested in doing that. So London Global Cancer Week will run for the 7th year this year. It's a series of over 40 curated meetings that are So really the USP of this event is that we hope it will democratise ability to access the content by nature of the fact that it's free, but also that it features not only the larger organisations such as the multilateral institutions and alliances, but also smaller NGOs and enables people that otherwise may not have a platform to speak about their work and encourage collaboration. So really key characteristics of the week are that it's a curated, diverse series of events, people from various backgrounds, as I've already stated, and where people can just highlight innovative solutions and progress that they're making that can be shared. And we hope that in doing this will promote coherence in policy making at national and international level by providing this space where people can have holistic discussions. So really the USP of this event is that we So one of the organisations, so one of the other and the third group that I wanted to highlight who also ran sessions this year and last year at London Global Cancer Week of the Global Coalition for Radiotherapy, another really dynamic group founded by Pat Price and Birgit Florent, with Darian Laird as the executive director. So this is off the back of the fact that radiotherapy is a vital treatment modality for over half of cancer patients and is involved in 40% of curative treatments, but it's not universally available and often neglected when developing national cancer control plans. So the mission of the GC one of the so I'd also like to highlight initiative so I'd just like to finish by encouraging anybody that's interested to attend London Global Cancer Week or host the session. We will hold it this year 24th to the 28th of November. Please visit our website. Very soon we will have ability to propose a session through the website. And from October this year, you'll be able to register for this year's sessions.
Well, thank you very much. We apologize for some inconveniences with the sound, but you can find all the presentations are recorded, and you can enter to the webpage of the London, you Google London Global Cancer Week, and you will find all the presentations completely recorded. And also, we ask you, if you are interested, to submit your session for the 2025 event. Dr. Sawawi, I think that we have some minutes for the...
Yes, I am sorry for the technical difficulty because the record of our friend Susie was not done in a way that was not compatible with us. But finally, Mahmoud beside me is the technical director and succeeded to broadcast the video as he can. But her copy with us. So if you need any the copy as sent by Susie, we are at your disposal. Now, please, Professor Eduardo Gazap, lead the conclusion remark with Carol Sikora, Professor Carol Sikora, Professor Nabil Mubarak, and Abba. Abba is the rapporteur also of not only leader, but also a rapporteur of the last second webinar. And Jack will be the rapporteur of this webinar. Okay, Eduardo, please.
Thank you, Ahmed. Please, can you open your video and audio, Dr. Sikora? And thank you very much for your in-person. And Dr. Malum, thank you very much. There are some questions here
Dr.
from...
okay. Dr. Nabil Mubarak is here.
Yes. Hello, Dr. Mubarak. Thank you very much for joining. There is, I think that several of the points raised here at the chat were already discussed, but at the beginning there is a question about screening from Dagmara Popravsky that says, what is needed to risk management to try to decrease incidence of malignancy well beyond screening, and that screening in Australia for breast and lung via track or buzzers, etc. So I understand that screening and risk reduction was not the topic of today, but if you have a couple of comments about screening and risk reduction, please, you have the floor. Who wants to make some comment? Yes.
Sorry. My thoughts were more about screening being available to everyone, because as you know, in big cities, it's not that difficult to get to a hospital. When you're in a rural place or a remote place, you really have to travel often up to 1,000 kilometers to get your screening done.
Australia.
So what Australia has mandated is that all screening will be available. And this is basically now mammograms and ultrasound equipment on buses for breast screening, low dose CTs for lung cancers on trucks, which travel from place to place and basically cover through the year all the outlying areas.
Thank you very much for your clarification. Who wants to open the
Yes,
the
from my
answers?
side, Professor Eduardo, it was a very nice meeting for me to attend. I think this your point about the cancer screening is very important, because as we know, we're going to be able to decrease the number of patients, and at the same time we can see patients at earlier stages, which gives us an opportunity for lesser cost. So I think this is really a very good option. Even in my country, in Egypt, we started as Professor Digmara was saying, the breast screening, the lung as well, and they're starting as well to add the prostate in the last couple of months. Thank you.
Thank you for your comment.
Yeah. May
Other
I?
views? Yes, please.
Yes, please.
Dr. Mahmoud.
Yeah, no, thank you for the opportunity. And indeed, in the last hour or so, we had various speakers have alluded on a low cost of systemic drug and others. But of course, the gentleman that raised the question of screening, for us in the low middle income country, that is one of the tools that we need to strengthen, because using the screening, as earlier my colleague has mentioned, that will enable us to have an early detection, prevention, and also reducing cancer-related mortality. And that screening will going to be from the high risk for breast, going for cervical cancer screening, the vaccinating the daughters, and then screening the mothers. So those screening need to be done, and it has to be holistically in the health sector system, especially in low middle income country. This is one of the tools that we have potentially to initiate within the workforce in order to reduce the cost of cancer care globally.
Thank you. Professor Sikora, your view.
Excuse me, I would like to have the point of view, if it's possible, of Scholar, not only on screening, but on the whole topic of the webinar today.
Yeah. So on screening, it's important, of course. The problem, of course, is that the resource for screening is in a different pocket of government funding than cancer care in many cases, and it's bridging the gap. Oncologists on the whole don't deal with screening. There's a difference, certainly in Britain and many other countries, it's a separate issue. The other problem, of course, if there isn't the capacity to deal with the disease when it presents, what do you do first? You prioritize screening versus actually taking patients into the system with known disease. So of course, screening produces false negatives. So you have patients, false positives that you have to sort out, and that costs money. In terms of the whole initiative, I'm a great believer that it has to be a sustainable program, and that's the problem all around the world. We don't have sustainable cancer care, and some of the data that was presented from Brussels from our South African colleague was tremendous. I mean, you can see it's just impossible. We're facing that sort of cost rise over the next 2 years. It's impossible to do. The journals are filled with adverts and papers. Those are funded. People get flown to meetings, to ASCO, to all around the place if they have positive results. You don't for common sense oncology, or choosing wisely, as Ahmed would say. There's no business class air tickets for going around the world to present that at conferences, because there's no monetary value in it. I think that's the problem with the whole thing. I think what we can do as doctors, though, is vocalize the need for common sense in this whole business, and not to try and have gold-plated care when the country can't possibly afford it. Because the difference, there is this therapeutic plateau in oncology. It's more so than any other clinical specialty. You put a bit of money in and you get tremendous gains. You start with tamoxifen for breast cancer, generic tamoxifen for breast, and you put a bit more in, you have adjuvant chemotherapy. You put a bit more in, you get radiotherapy with IMRT and so on. But eventually you come to a top and it plateaus right off. You increase the cost dramatically and you get nothing for it. And in the US, most patients are way on that therapeutic plateau. In Britain, we're sort of on the cusp of it, or maybe even below it. In many countries, it's way below. And that's where we have to put the effort. And I think that's what this is all about, and what your initiatives, Ahmed, of both win-win, choose wisely, all these things are the same thing. They're all about not going down that therapeutic plateau.
Yes, of course, thank you for your comments. Evidently, we have here two different approaches, and I choose the question about screening. We recognize that was not exactly the topic for today, but it is the only available tool to reduce the costs of cancer treatment that we have available today. Because if we have low volume disease, if we have early detection of disease, everything will be easier, more curable, and cheaper. The other issue, of course, that is related with the cost of drugs, I have perhaps a different vision, in the sense that the reason of the cost of the drugs are so disseminated because it's in many systems the only cost that we know. If we ask for the cost of cancer surgery in many countries, that is a question that is unanswered. And for example, in the case of the healthcare systems of my country, Argentina, I was talking with the people of the agencies about the cost of drugs, and they are not concerned about that. 50% of the cost of the health system in Argentina is disability, especially in young people, transportation, education. If you analyze the cost of drugs in France, not in a short period of time, in a long period of time, number one, drugs are for lowering the cholesterol are antihypertensive agents, because those agents are used and provided by the system for decades. So, of course, I agree with all the concerns about the individual cost of each treatment, but that is something unavoidable when you have at the beginning an early thing. A computer at the beginning was very expensive, and now are made much more cheaper. We have a short time, so I think that if we move at one question that I think is interesting to know your opinion about genetic differences and populations. The question of Dr. Tendwa is about considering the genetic diversity of cancer-related genes. How do we address and implement issues of pharmacogenomics in relation to precision medicine? I think that this is a challenging question, because precision medicine perhaps is costly at the treatment level, but can be used in other ways to select patients and to avoid unnecessary treatments. Please who wants to open the discussion for a couple of minutes? Do we have a couple of minutes more, Dr. El Sawawi?
I would like to say that our next fourth and fifth seminars are about this pharmacology and all these interesting things. Now, this session was about a view of some of the different initiatives. So we'll send to you, and it is available, and we send you the link. It is available. We sent in every message from us, and please, I hope that I'm not bothering you. You will have a link to all the chapters and videos and the material for the next topic, which how to use science to decrease the cost of cancer therapy. And it is not exclusive. You will find what we stated as a lot. So I'll send it to you all today again, and please read it, and please not just come with question after, but come with some suggestion. We start from now, the next session. And this session is not finished now, but it is a start of a way. We are building step over step over step. Today is a step, and the upcoming step is we need, and will be very valuable to read the material and to come with more suggestion to add with the examples that we say. There are a lot to do in the world. And also the question of cost. We are stressed on this, not the cost of drug, the cost of total cost. That is why you will find that in some approaches to reduce the cost of chemotherapy, for example, to lessen the period of hospitalization, to lessen the toxicity, to lessen many things. So it is not just the cost of drug. In surgery, as we discussed together before, Professor Eduardo Gazab, the approach of surgery and how it is to reduce the nights of radiation. And I sent again to all the video of that led by you. Do you remember of World Cancer Leaders? And we speak also about surgery, how to reduce this. And that's why we have a branch of our activity for surgery led by Ricardo Odesio. And we have before 15 webinars of surgical oncology. This is a broad effect. And again, we say that it's not the fish, not the chicken or the egg. I agree with the previous approach with Carol Sikora. He presented in 1998. Do you remember the global strategy for global strategy for new millennium? It is the same patient. It is the same patient who screen, the same patient who treat. If we are oncologists and we are treating, but we are not against screening. Screening is how to get earlier cases. So it is connected to each other, and not the question. It is screening or treat, screening or palliative care. No, what you do is patient is screaming already advanced. You say that I treat early cases only. No, this should be palliative care. So all, as Carol Sikora specified exactly in the global strategy for the new millennium, it is global balanced approaches. If we are specialists in oncology and treatment, that is not to say that we are against screening, diagnosis, pathology, treatment, palliative care, research it, and relevant futuristic approach and economical study. This global approach, but why are we specified in this? Otherwise, if I give advices in pathology, which is very important, there are many other people who can do this. So this is how to reduce the cost of treatment, radiotherapy, chemotherapy, surgery, and all aspects via science. I'll send you material today, not as a reference, but as a base. Please add to us. Please add to these examples with publication, with evidence. We don't know all. So, Professor Eduardo Gazab, please close the session with the...
Well, thank you very much. I think that the issue was that to my knowledge, the majority of the concepts that we need to transmit were extraordinarily presented by the speakers. And the summary and the presentation from Dr. Sikora is a perfect summary of the concept. So my idea was to try to perhaps take a little bit of other matters that were not exactly presented today. But absolutely, the topic for today was the reduction of the cost of treatments. But please remind that when we are having this type of discussions, we have to consider 4 levels. The level of the doctors with the patient, that is a personal conversation. The level of the medical recommendation, gold standards or guidelines, that is the scientific recommendation.
Yes.
The third levels are constituted by the healthcare systems and the country decision about healthcare, and that is a medical and political decision. And the fourth level is the global level. And if we analyze, in my view, we are talking about the third and fourth level, because the second and first are out of the discussion. It's the best possible care from the doctor and the best treatment according to the norms and procedures of the medical and scientific organizations. My point is that in general, we are talking, as we discussed, about how countries and the global international community can afford or really provide all the things for the total population. And that, my dear friends, I think that today is, with the cost, is impossible. This is not possible for 8 billion population people. Screening with mammography is impossible because we do not have the equipment. So if we are talking really at the policy level, at the global level, that is a way in which we need to focalize the strategies. We are not discussing the best possible care that is very well known by good doctors. Dr. Sikora, your final comments, please.
Well, Ahmed, congratulations on setting this up. You've made us all think, which is great. And Eduardo wonderfully chaired. So I know the technology is not the best, but it never is, even in this modern world. I think the message is very clear. We have to use resources more wisely. We just have to. Healthcare is inevitably rationed. We have to get over the fact that it's rationed, but use that rationing in a much more rational way, I guess. And so congratulations, well done for fixing this up. Thank you.
Thank you all very much. And the final words, of course, Professor El Sawawi, you will close the webinar of today's
I thank
webinar.
you all. We have, all of you can say a lot, I know, but so excuse us for the limited time. But what is said today is jewels, but we have a treasure of jewels upcoming, and you will add to this. This is just a point to improve this, to increase this. This is by you all, and really we are honored by all of you, by honor of all colleagues who presented, and the younger colleagues, please ask them to join, because who will lead the future. We'll send you materials, and please be reactive and send feedback and send addition, say criticism. All it is yours. Thank you all.
Thank you
And
very
I
much
would like
to
to
all the
thank,
participants.
yes,
Thank
I
you
would,
for your attention.
thank you. I would like to add something, but how I forget this. To thank ASCO, and to thank Professor Robinson, the president of our ASCO, with her encouragement and supporting morally and many things, and for the team of ASCO International and ASCO Global Impact, and all colleagues who shared with us. Thank you.